Thank you. It's great to get on to this next section, which deals with some of the quality of life issues that are associated with these tumors. And I'm very happy to introduce Dr. Jeffrey Wefel, who is Associate Professor in the Department of Neuro-Oncology at MD Anderson. He's also the Section Chief for the Section of Neuropsychology. So he has extensive training in clinical neuropsychology, starting at the University of Chicago Medical Center, and then doing a fellowship here in MD Anderson Cancer Center, after which he joined faculty track here. And he's currently a tenured associate professor. So his reputation is extensive in the field of neuropsychology and brain tumors. He is a leader in the field and has been participant in some of the largest of the trials that have ever been done in brain tumors. And he's an international authority in this area. So he has numerous publications, including in papers like New England Journal of Medicine. And he's an authority on neurocognitive changes, neurotoxicity, as well as intervention in terms of improvement from a neurocognitive perspective. So with that introduction, I'd like to welcome him to the stage to talk about neurocognitive aspects of neuro-oncology and update. Jeff, all yours.
Thank you so much, Dr. Puduvali, and thank you, Dr. Valdivia, Sinning, Lang, and Puduvali for inviting me to be a part of this webinar. So these are my disclosures. And this is an outline of what I hope to cover with you here this afternoon. I first want to spend some time talking about the scope of the problem that we face in terms of the neurocognitive deficits that our patients encounter and the challenges in enhancing their function and maintaining their function over the course of therapy. And I'll walk you through some of the more recent advances in our understanding of the nature, mechanisms, and risk factors for neurocognitive dysfunction in patients with brain tumor, and then share with you some of the clinical trial results specifically of recent efforts to prevent neurocognitive decline while caring for patients with brain tumors. So why is neurocognitive function important, or why concentrate on this? And really one of the reasons is that patients and caregivers have said this is a priority. The Jump-Starting Brain Tumor Drug Development Coalition performed a survey in advance of some meetings that they had with regulatory agencies in the United States, cancer treating professionals, as well as other interested parties. And this patient and caregiver survey, they asked the question, in addition to allowing a person to live longer, what would you most like to see future brain tumor treatments do? And the top three responses you can see here, the first of which was retain brain function, right? To maintain our ability to think and act as we intend, to maintain our physical abilities, and to reduce pain and suffering. So we know that brain tumor patients suffer from multiple signs and symptoms over the course of their illness. 3/4 of patients have 3 or more symptoms that are endorsed by them as being moderate or severe in nature. And the top 3 symptoms that they report are probably no surprise to many of you who care for these patients. They're tired, they have sleep disturbance, they've had cognitive changes, alterations in their thinking skills, and they have mood disturbance. And this is probably one that's less well appreciated sometimes by us clinically. These difficulties are oftentimes creating functional limitations in their life in terms of difficulty returning to work. They may have, movement difficulties as well, and may suffer from diminished ability to carry on some of their typical activities of daily living in more of a minority of patients, and maybe 1/4 of patients. They also encounter neurobehavioral changes, personality changes, irritability, frustration, and these can be the most difficult for families and caregivers to manage. And only a fraction, as I said, return to competitive employment. And this may be with some accommodations like reduced hours, increased work limitations, or increased need for time away from work. I have created this cartoon to outline a number of the contributors to and the impacts of neurocognitive dysfunction on our patients. And within this diagnostic phase, we can see that tumor location certainly has a strong relationship to the types of cognitive deficits that we see. But I also want to bring to light here that the genes, your germline genetic makeup, also seems to moderate the ability for these therapies to cause problems. As you'll see, molecular genetics in the tumor also have an impact on the presentation of cognitive deficits. And then brain reserve, brain resilience, and cognitive reserve also seem to modulate the impact of these therapies on the development of cognitive deficits. And across our treatment and survivorship phase, patients are encountering surgery, radiation, chemo, and additional therapies, in addition to carrying their own medical comorbidities, requiring other medications that may have impacts on brain and cognition. As I said, psychological and psychiatric disturbances. And collectively, all these are going to bear an impact on a patient's life, their ability to carry out their desired activities in the home, their work, and their social lives. So I think one of the things that we've appreciated more recently is whether or not we can really consider a brain tumor a focal or a diffuse disease. And we can see that brain tumors, of course, occur in many different locations. But we also know that even what we're seeing radiographically does not represent the full extent of the disease, that when we look at this under the microscope, as Dr. Hughes can do, we can see that there are tumor cells littered throughout the brain, and thus we need therapies oftentimes that chase down those tumor cells in far-reaching parts of the disease. And this is quite a challenge when they're interdigitated with normal tissues. Using magnetoencephalography, as well as other approaches like fMRI that we heard about before, you can also see that in contrast to healthy controls brain organization being very connected, both locally and distally, the impact of a brain tumor, this low-grade glioma here, disrupts that functional organization and functional connectivity in this patient population, but not just around where the tumor is located, but also we see loss of functional connectivity in distal regions. And this partially contributes to obviously some of the challenges, but some of the deficits in brain tumor patients appearing less focal than in stroke populations. So we had the opportunity to dig into our data sets here at MD Anderson, and we wanted to understand the differential cognitive presentation of patients who have tumors in the left versus right temporal lobe. And we had been referred over 100 patients for preoperative examination, about 70 of which had a left temporal lobe lesion and 30 had a right temporal lobe lesion. And they were otherwise very similar in terms of clinical and demographic characteristics as depicted in this table. We then also went about segmenting the temporal lobe into an anterior portion, a posterior portion, a medial portion, and if they had tumors that crossed multiple regions, then we designated them as multi-zone involvement. When we looked at the neuropsychological profiles of these patients, you can see here in the blue bars, areas of cognition where patients who had left temporal lobe lesions were performing worse, substantially more impairment than individuals with right temporal lobe lesions. And across all cognitive domains, about 3/4 of patients evidence cognitive impairment. And this is defined as a performance on a test that is 1.5 standard deviations below the healthy control population's mean. And this was about the same rate for both left and right temporal lobe patients. However, as I said, the left temporal lobe patients had learning and memory deficits at very high rates. They had high rates of executive function difficulties, but they also exhibited difficulties with expressive and receptive language abilities and auditory attention, which is understandable given lesion localization and language lateralization. It was maybe somewhat more surprising for us to see that there were these very high rates of verbal learning and memory deficits in the right temporal lobe patients. And this really underscores that connectedness, this bilateral connectedness of the temporal lobes that I think is increasingly appreciated, that it's not always such a lateralizing feature that will have isolated verbal memory deficits or visual memory deficits dependent on the lateralization of the lesion as well. When we started digging into the anatomy of the temporal lobe and the localization of these tumors and its relationship to profiles of cognitive impairment, and we do this by dissecting across the various components of our learning and memory task, what we saw was that when patients had anterior and posterior zone involvement in the medial temporal lobe, that there was evidence of reductions in learning efficiency, but there was relative preservation in memory consolidation and retrieval processes. However, when that tumor was medially or multi-zone involvement, then we were seeing much more of an amnestic memory disorder or a reduction in memory consolidation capacity as well. So with this information, it's easier for us to predict the cognitive profiles and the cognitive risks of operative procedures in these areas. We know that getting a large extent of resection is very important. It's been demonstrated that having a resection of 98% or greater, and even now these super total resections that I think we heard alluded to earlier, can be associated with improved outcomes and increased survival time. However, we know there's also neurocognitive risks and risks to neurologic function has been described already by numerous speakers. And in this case, this is a small sample of patients that we saw pre and post-operatively. And what I want to focus on maybe is just one domain here, memory. And you can see here that we had frequent neurocognitive decline, yellow, orange, and red representing mild, moderate, and severe neurocognitive decline post-operatively relative to baseline. And over 50% of patients, they experienced some degree of cognitive decline, and this was moderate to severe in a quarter. But we also see in blue here that about 20% or 1 out of 5 patients experienced improvement in cognitive function post-operatively. And so a question might be, how do we identify these patients and select them or reduce morbidity? So at MD Anderson, it's common practice to refer patients for preoperative neuropsychological evaluation. And through years of doing this, we aggregated data that allowed us to address this in a research study in which we found that preoperative neuropsychological function was a significant predictor of postoperative memory decline. And what you see here is a multivariate model demonstrating that performance before surgery on this learning and memory test was a significant predictor, a prognosticator of postoperative memory decline. And what I think this is going to lead us to be able to do in the near future is to develop a bit of a risk prediction calculator where these clinical, demographic, and imaging, as well as neuropsychological variables can be plugged into a risk calculator, and then a score could be output that would help inform the surgical risk for patients and providers. And in our particular practice, as you heard from Drs. Kumar and Prabhu already, we are also increasingly integrating intraoperative cognitive monitoring with direct electrocortical stimulation and subcortical stimulation using tools like the NeuroMapper. And it has been demonstrated by a German group led by Kelm et al. That the use of neuropsychologists in this capacity in the OR has led to shorter durations of surgery, increased gross total resections with no increases in post-op deficits. So what about the tumor itself and its molecular characteristics specifically? For a long time, we had been interested in tumor momentum as a driver of the development of the presentation of patients with greater cognitive deficits, but we did not have a rigorous way of determining which tumors were growing faster versus slower. And with the characterization of the IDH component of the tumors, this genetic mutation, others demonstrated that these wild-type tumors were growing much more rapidly than mutant tumors. And we, again, went back to our neuropsychological database and partnered with Dan Cahill, who was a neurosurgeon at MD Anderson, who had characterized the IDH status of these tumors in his lab, and grouped patients that we had seen preoperatively into IDH wild-type patients and IDH mutant patients. And then we looked at the profiles of their cognitive performances. And what you can see here plotted in this graph are our cognitive test battery, and I've organized these by domain below, as you can see. And the yellow bar represents a relatively normal level of function, what we'd expect if there was no brain tumor. And you can see that the patients who have IDH wild-type tumors, this is the blue lines and dots, are having a suppressed performance relative to their counterparts who have IDH mutant tumors. And these were statistically significant for domains like learning and memory, processing speed, executive function, language, and bilateral motor, fine motor control. So these patients were presenting with much greater cognitive deficits despite having similar lesion size. And we thought that this was secondary to the greater lesion momentum that may potentially preclude the brain from initiating compensatory neuroplastic processes and reorganizing. To further interrogate that, we then took their MRIs and we subjected them to this image processing pipeline using voxel-based morphometry, isolating ROIs within the brain, and then doing connectomic analyses. And what we demonstrated was that the IDH wild-type tumor patients had fewer connections, as can be hopefully appreciated in this ball and stick diagram. There's less dense connections between the balls. These are the sticks, or the edges, as they're referred to in connectomics. And there was fewer hub regions, fewer well-organized large green balls representing areas of the brain in which many, many pathways are coalescing and representing critical areas of cognitive processing. Using connectomics mathematics as well, we're able to calculate an efficiency metric, and it was demonstrated that the connectivity of the brains of patients who had IDH wild-type tumors represented a less efficient connectivity matrix than those who had mutant tumors. And so we think collectively what we've demonstrated is that these tumors and the genetic features of these tumors specifically are disrupting the brain in different ways and causing different cognitive phenotypes associated with these genetic aberrations in these tumors. we also know that many of the treatments that our patients are exposed to, including radiation and chemotherapy, can be associated with cognitive deficits, but not all patients experience these deficits. And increasingly, we're identifying genes that we have and SNPs in these genes that may increase our risk and may also conversely be protective factors against the adverse effects of these therapies. So I think many of us are familiar with the pathogenesis of radiation damage, and I like this timeline approach of thinking about the neuropathological changes. And what we realize here is that many of these neurodegenerative processes are initiated very early in the hours and days after receiving radiation therapy, and certainly in the weeks and months moving forward. And they include things like vascular endothelial damage, inflammation and microglial dysregulation, oligodendrocyte and oligodendrocyte precursor cell injury, neuronal damage and altered neurogenesis, and epigenetic aberrations. We also know that a number of modifiable factors, radiation treatment factors, such as fraction size, dose duration, the volume of the brain that gets exposed to radiation therapy, including the hippocampal exposure, have been associated with increased risk of cognitive dysfunction. And many of these, many of this new understanding of these risk factors have led to some new approaches to try to prevent these adverse effects that I'll go over with you here in a few minutes. Again, what we've now begun to elaborate is a better understanding of the topography of risk within the brain when it's exposed to radiation therapy. And the group in San Diego has demonstrated regionally selective dose-dependent atrophy of gray matter at 1 year after radiation therapy that tends to preferentially occur in entorhinal cortex, in the hippocampus, but not as much in the paracentral lobule. So there seems to be some topographical distribution of risk in terms of tissue toxicity as well. There is also regionally selective dose-dependent disruption in white matter integrity as measured by fractional anisotropy at 1 year. And this seemed to be more prevalent in the fornix, the cingulum bundle, and the body of the corpus callosum. When looking at the expression of the development of neurocognitive deficit over time in lower grade glioma patients, the Dutch group examined patients who had lower grade gliomas and who had undergone neurocognitive testing before and 12 years after radiation therapy, and observed this somewhat linear decline in cognitive functions such as executive function, psychomotor ability, working memory capacity, and attention, but interestingly failed to observe any declines over time in measures of verbal memory and less decline in information processing speed. In the RTOG and what's now called NRG oncology, we performed a study, RTOG 0424, in which patients with lower grade gliomas were treated with concurrent chemoradiation and then up to 12 cycles of adjuvant temozolomide. And they were monitored over time with cognitive testing and quality of life measures. And we looked at them at baseline at 6 months after treatment and 12 months after treatment. And what was observed there was that at 6 and 12 months, 50 and 40% of patients exhibited some evidence of cognitive decline in some domain, most commonly in information processing speed and learning and memory function, as well as executive function, as we can see here. And in this particular trial, using very sensitive neuropsychological tests, clinically validated gold standard tests, cognitive decline in memory and processing speed were frequent and earlier, much earlier, as we can see, than noted in prior studies. And risk factors for this cognitive decline included being grouped into the EORTC high risk group and having a tumor crossing the midline. So this certainly is now indicating to us that while these therapies we're directing at tumor control are very effective or increasingly effective and we think are quite necessary, they may come with some costs, and we need to be monitoring and addressing those as early as possible. As I said, not every patient experiences these adverse effects in this cognitive decline, and we think some of this is moderated by germline SNPs. So we had assessed longitudinally 102 glioma patients at MD Anderson, and we had obtained blood for genotyping these patients. And when we looked at this, we identified over 9,000 SNPs that mapped to over 500 genes in 5 pathways: an inflammatory pathway, a DNA repair pathway, metabolism, neurocognitive, and TERT pathways. And we observed that polymorphisms in telomerase, DNA repair, and cognitive pathways were independent predictors of neurocognitive decline in glioma patients. And we also observed that there was a SNP dose effect. So if you had at-risk genes in multiple pathways, then this increased your risk of developing cognitive decline over time. And we think with some more time and some more work in these genetic analyses that this could inform clinical surveillance guidelines, treatment intensification decisions, and the development of rehabilitative and neuroprotective interventions. And I also want to be sure to let you know that these are not the only genes that have been examined and identified so far to be associated with the development of neurotoxicity. The ApoE4 allele is also commonly associated with worse outcomes in patients who harbor that SNP. And then there are also SNPs in things like catechol methyltransferase, brain-derived neurotrophic factor, DTNBP1, and others as well. So one approach to trying to mitigate against the adverse effects of radiation therapy has been to try a new radiation therapy approach that has less normal tissue exposure, and that is proton radiation therapy. And the Mass General group has retrospectively looked at their patient population whom they treated with proton therapy, again, sparing more of the normal brain and concentrating the therapeutic dose at the tumor compared to conventional radiation therapy. And what they observed was that the low-grade glioma patients generally were not performing in the impaired range, a Z-score below 0, but they also noticed that they were not really performing at the expected levels of their matched healthy controls. At MD Anderson, we performed a randomized phase 2 trial in a high-grade glioma population in which patients were randomized to proton radiation therapy versus intensity modulated radiotherapy in newly diagnosed patient populations. And in the high-grade population there, we observed no therapeutic benefit from proton therapy in delaying time to neurocognitive decline. You can see these curves overlaid on each other. But it was observed in our toxicity studies that proton was associated with less patient-reported fatigue. So what are some other approaches that have been studied mainly in brain metastasis populations, but may be informative toward treating other brain tumor populations? So in the brain met population, there had been a long ongoing controversy about the use of whole brain radiation therapy and its association with neurotoxicity. So we performed one of the first studies at MD Anderson that randomized patients with 1 to 3 brain mets to SRS or SRS and whole brain. And this was then repeated in the large cooperative group trial run by the NCCTG. Both studies finding that patients who received SRS and whole brain radiation therapy had better intracranial tumor control as expected, but they also were at greater risk for cognitive decline. They had double the rates and triple the rates of cognitive deficits after their treatment compared to individuals who were treated with SRS alone. And there was no difference in overall survival time. So this intracranial tumor control did not convert to any extension of overall survival time and was associated with worse toxicity. We do know, though, that some patients require whole brain radiation therapy. They may have too many metastases or too large of metastases to be addressed through SRS techniques. And in those cases, we wanted to ask the question about whether or not we could protect the normal tissues using the drug memantine before and during whole brain radiation therapy. So in RTOG 0614, patients with brain metastases were randomized to memantine or placebo. And we observed that memantine delayed the time to cognitive decline in this patient population. We further identified that the ApoE4 allele, again, was a significant risk factor for worse cognitive decline over time when exposed to whole brain radiation therapy, whether or not you receive memantine. So the E4 allele appears to be a clinical biomarker of risk for greater neurotoxicity after treatment with radiation therapy. These concepts now of a technological and a pharmacological approach of protecting the brain have now been wedded, and in NRGCC 001, we just recently presented the results of a phase 3 trial in which patients were treated with memantine and whole brain radiation therapy, or memantine and hippocampal avoidant whole brain radiation therapy. And we demonstrated that in patients treated with the hippocampal avoidance, that again, we had prolongation of the time to neurocognitive function failure with no worsening of PFS or OS. So with that, I hope I've explained some of the contributions that neuropsychologists have made in this area and some of the opportunities for the future, and I'd like to thank all my collaborators that have contributed to this work and appreciate the opportunity to be here with you today. Thank you.